Now, the source of case selection in a case control study can vary. Sometimes case control studies are population-based, so they are derived from surveillance systems or some other large healthcare system for which data are routinely collected for other purposes. Patients may be identified via medical practitioners or any other source in that system. For example, there also are large case control studies that are performed using large healthcare databases, such as private insurance databases. And again, the purpose of those databases isn't for research necessarily. However, the data are collected such that a researcher could go in and use some of that information to do a case control study. Another kind of case control source would be a hospital-based source, and hopefully that's somewhat obvious, but to choose cases and controls from a hospital system, which is a very specific population, and presumably among the cases and the controls selected, they're selected around the same time period of hospitalization and the same variables were collected. So there are issues in case selection in a case control study, and they have to do with how the cases are selected and whether or not they truly represent all the potential cases that could occur in the general population of people. Depending on the source of the cases, there could be a bias. For example, if the case control study is performed using a hospital-based database, that population may differ from the general population who could become cases. Perhaps they're sicker, or they have better or different access to care than other individuals who aren't hospitalized. And because of that, there could lead to issues in the external validity of the study results. Also, if data are coming from certain medical clinics, that those could be biased or influenced by different types of medical practice, as well as the level of care being given. And then also when choosing cases, one has to think ahead in terms of whether or not you're going to focus on incident cases, and that those are cases that you're observing occurring, or prevalent cases, which are cases of disease that already exist, and you're just measuring for them. You're observing them, not observing them, but you're seeing them or reporting them in the population. And the difference between the two in terms of their importance in a case control study is that with an incident case control study, because you're observing the cases as they occur, you're dealing with new cases, and there's a better control in that design for issues that have to do with the duration of illness or the duration of the disease. If we're dealing with just prevalent cases, there could be error or noise introduced into our estimate depending on the disease. So if we're dealing with a prevalent study a case control study where the cases are prevalent, let's choose heart disease. Well, there are different levels of heart disease, and there are heart disease is a chronic disease. So a person could have heart disease at the age of 60 or the age of 75. However, those two individuals probably differ in other characteristics. So simply including them in a case control study without accounting for those other characteristics, again, may affect your overall estimate. Now, prevalent cases are situations where they're available at the time you start your case control study. So from a logistics perspective, doing a case control study using prevalent cases is faster and less expensive. However, use of prevalent cases may lead to an overrepresentation of survivors and introduce that survivor bias, because if you're dealing with prevalent cases, and they're living, you've already the people who had the disease and died would not be accounted for, and so those who are still living and have the disease may be different from other people who had the disease and might have died from it. And so that could be tied to certain risk factors associated with their survivorship. Now, use of incident cases is ideal, but as I said, it's more time consuming and oftentimes more of an expensive approach. because it requires a longer observation period to identify those incident cases. So survivorship and risk bias is less of a problem in incident case control. However, these types of studies take longer to perform. As far as the characteristics for the controls, well, they too should come from the same source population as the cases, and so they should be also be generally representative of the overall population who would be at risk for developing the disease. And they should be comparable to the cases on all factors, really, except for the risk factor, which again should not be known at the time of the case and the control selection. Ideally, controls should be randomly selected from the source population among non-cases and should be generally from the same time frame as the cases. And they are also at risk of becoming a case at any time until they're chosen to be a control. Multiple areas where population-based controls can be there are various sources of population-based controls. For example, they can come from just a random sample of the total population or from the source population. It could be neighborhood controls. Sometimes these are performed in an attempt to control for factors that vary across regions. So if we're dealing with a case control study, we may want to choose controls among residents who live near the cases. Similarly, you could choose controls from the same medical centers or hospitals, and these controls would consist of patients who were seeking care for something other than the disease that you're studying, because again, they're controls, they don't have that disease. You can also get controls from a registry system, which is a system to track epidemiological systems to track for the outcome of a certain disease. And also sometimes controls can come from the friends of cases. Specific to choosing controls from a hospital system, well, the beauty of this is that you are collecting a group of controls who are similar in terms of location and time as the cases, so they're viewed as somewhat of a captive population. However, they don't often resemble the general population of persons who could be at risk for having had the disease. As I said before, they could be sicker. They could have other risk factors that may influence the measure of association between your disease and your exposure. There are a lot of questions involved in who to select if you chose a hospital-based control system, a hospital-based cohort, and also to determine if you're going to use a control from a hospital, what other diseases are you willing to include or exclude in that group? Because again, those factors may also affect the relationship you're looking at between your exposure and your outcome.